Let's begin with our today's lecture of infectious medicine, and the two topics which we will discuss in our today's lecture will be the coccidioidomycosis and then blastomycosis. First, coccidioidomycosis. This is the fungal infection which is caused by the breathing of the fungus, and then it goes or enters the lungs and cause pulmonary infection, and then later on it can spread to the other part of the body also, but it is usually the asymptomatic acute form of fungal infection. So breathing in of the spore of the fungus begins the infection of coccidioidomycosis. Mycosis is the fungus. So whenever we see the term mycosis, that's the fungal infection. And this is the fungal infection caused by the Coccidioides. So coccidioidomycosis caused by the breathing of the fungus, and it causes lungs infection. The fungus that caused the coccidioidomycosis is Coccidioides, and that's the you can see the septated. It's a septated fungus. You can see the septa, and that's the picture of Coccidioides, which is the fungus that caused the infection Coccidioidomycosis. The life cycle of coccidioidomycosis is, first we saw that septate fungus picture in the previous slide. That's the arthroconidia. These are the arthroconidia causing the infection caused by coccidioides, causing coccidioidomycosis, and that's the arthroconidia. This arthroconidia, then if these are the infected propagule, these are the propagule, and these are the infected or infective propagule that is responsible for the causing of the infection as a result of breathing in and cause the pulmonary infection or infection of the lungs. So first we have arthroconidia, and these, if you see, these are just the broken parts of arthroconidia known as infective propagule. These infected or infective propagule, what happens is they form growing arthroconidium. If you see, they are growing and getting bigger, and they are the growing arthroconidium. Next, after the growing and after forming growing arthroconidium, then they form a big structure, rounded form known as the spherule. This is the spherule. This spherule then form a septated spherule. Now you can see there are the septa form, and this is known as the septated spherule. In this septated spherule, then this becomes the segmented. It breaks down into different segments, and it's known as the segmented spherule. And this segmented spherule, then inside this segmented spherule, the endospores are formed. And this endospore formation and then the rupture of the endospore causes the release of the endospores, and these are the endospores once they are ingested or inhaled. They are inhaled or they are breathed in the lungs. They cause the infection known as Coccidioidomycosis, and this is the endospore release or endospore formation. So if we go over the life cycle, we have arthroconidia. Arthroconidia forms infective propagules. These infective propagules, they grow and develop and form growing arthroconidium, and these growing arthroconidium form spherules. Spherules form septated spherule, then segmented spherule. These segmented spherules form endospore, and then there is release of endospore from the segmented spherule or from the endospore. Then the pathogenesis of coccidioidomycosis. The pathogenesis is, again, as we saw in the previous slide, we have arthroconidia. These are the arthroconidia. Then there is spherule formation. This is the spherule initial, first spherule. Arthroconidia converted into initial spherules. Sphere, the term comes from the sphere, which is the round form. So initial spherule is formed. Then this spherule, inside this spherule, you can see there are endospores are produced, so many endospores. These endospores, they release and they are breathed in and they cause infection. So after the release of endospores from these spherules, now what happens next is these endospores, they bring about some changes in the dendritic cells and the macrophages cells, which are the immune cells, because macrophages are the cells which are responsible for engulfing any foreign organisms or invading microorganisms, and that causes the destruction. So here at this point, when endospores which are released on the surface of the macrophages and dendritic cells, we have the receptors present. And we know the function of the receptors is the binding or attaching the foreign body that attaches to them and then brings some changes in them, so that initiate the process of destruction or pathogenesis, the phagocytosis. So here, these are the receptors which are present. The one type of receptor is C-type lectin receptor. So this is C-type lectin receptor. You can see the endospores come and attach to C-type lectin receptor. And the other receptor is the toll-like receptor. So both C-type lectin receptor and the toll receptors, the endospores are attaching to those receptors, and as a result of this, there is the endospores enters inside the cell from the receptors, and then it brings some changes, cause the production of we have the CARD9, and then we have MYD88. These brings in the genomic changes in the genome of the cells, and it causes the production of factors like IFN gamma, interleukin IB, and interleukin 23. All these are the chemical mediators that helps in the inflammatory process. So So endospores, which are released from the spherules, attach to the receptors on the surface of the macrophages, and then these receptors, which endospores which attach to the receptors, causes the release of chemical mediators like IFN, gamma, interleukin IB, and interleukin 23. Then it again, these mediators cause the T helper cell 1 and T helper cell 17. These are the protective T cell, immunity cell, and they protect against the infection and they fight the different infection. So if we see the pathogenesis that cause this inflammatory reaction to the Coccidioidomycosis, Coccidioides, which is the fungus that cause Coccidioidomycosis. The endospores are attached and they cause release of chemical mediators, which in turn cause the helper cell activation, and these T helper cells play an important role in the immune system. Next, the pathology, that's the pathological microscopic appearance of the coccidioidomycosis in the lungs, and that's you can see the spherule, very characteristic of the infection caused by the coccidioides. And another also, you can see a big spherule, growing spherule with the endospores in it, and then these endospores are released and then different chemicals are released and it initiates the process. So these are the microscopic slides or microscopic appearance of the coccidioidomycosis infection. Next, what are some clinical features associated with the infection? We have usually asymptomatic. 60% of the patient who have infection caused by coccidioides they are asymptomatic, means they have no symptoms develop, and then the condition usually resolves. So 60% of the cases are asymptomatic. 40% of the patient have symptomatic coccidioidomycosis, and the most common is the pulmonary infection, and the features associated with the pulmonary infection, cough, dyspnea, chest pain, all these are present. So 60% patients are asymptomatic, 40% are symptomatic, and since the infection is caused by inhalation of the fungus, so the lungs are the major organ affected by the infection. And then features: fever, as I mentioned, and there is cough, chest pain, pleuritic chest pain. Pleura is the covering or the lining that covers the lung. So there is pleuritic chest pain, there is fever, there is cough. Then clinical features of primary pulmonary coccidioidomycosis. We have cutaneous manifestation. It initially mainly involved the lungs. Pulmonary infection is common, but besides the pulmonary infection, we have other organs of the body affected, and how the patient with these infections or the involvement of these organs will present. First, the cutaneous manifestation. Cutaneous is the skin. These are the manifestations. We have toxic erythema, erythema nodosum, erythema multiforme, arthralgias. All these are the clinical manifestations caused by the spread of the infection to the skin, to the other parts of the body, to the joints. So we have different features, and that's the chest x-ray of the patient with coccidioidomycosis. You can see there is effusions, and there are very hilar markings are very prominent in the chest x-ray. Arthralgias, pain in the joints. Arthritis, inflammation of the joints become red, swollen, painful. So we have arthritis also. Night sweats are common in patients with this infection. Profound fatigue. Peripheral blood eosinophilia, increased level of eosinophils are present in the blood. It's an important feature in different fungal infections. Hilar or mediastinal lymphadenopathy, there is enlargement of the lymph nodes in the hilar region or in the mediastinum. Mediastinum is the structure between the lungs which contains the great vessels and the heart. So there is lymphadenopathy or enlargement of the lymph nodes and the pathological changes in the lymph node. Pleuritic chest pain is again also very common. So all these are features associated with coccidioidomycosis. 60% patients are asymptomatic, 40% are symptomatic. Main symptoms are associated with the lungs, causing the lung infection because the infection is caused by inhalation of the fungus, and this causes the cough, fever, chest pain. Then we have other features also associated with the skin like erythema nodosum, erythema multiforme, toxic erythema, involvement of the joints causing arthralgia, arthritis. So these are some characteristic symptoms of the patient with coccidioidomycosis. And then also we have pleural effusions. You can see the pleural effusion, which is the fluid in the chest, pleural effusion. Complications of the infection, the complications associated with coccidioidomycosis, pulmonary nodules are formed. So we see the pulmonary nodules are present. Calcification is uncommon, so nodules are present, but the calcification of the nodules is uncommon. There are cavities formed in the lungs as a result of the lesions of the lungs. There are cavities formed in the lungs. Pneumothorax, there is pus. Pio is pus, pneumo is air. So presence of pus and air in the thoracic cavity is also present. And then we have diffuse reticulonodular pulmonary process. All these are the complications associated with coccidioidomycosis. Next, the chronic infection. What are the features associated with the chronic pulmonary infection? So if the infection stays for a longer duration, we talked about the features of acute pulmonary infection and the cutaneous lesions. Now the chronic features or chronic clinical presentations, there are cavities. You can see now we have cavities form. Because of the chronic lesion, you see the cavities, and inside the cavities we can see some fluid level also, which might be fluid pus formation. So this is in the chronic infection. When the infection is present for over a long period of time, it forms the cavities in the lungs. So these are the pulmonary cavities, very, very clear X-ray of the cavities. Then there is fever associated with chronic cough. Weight loss is also present. And there is pulmonary scarring. Scarring of the lungs is present. Fibrosis. Again, very, very important. You can see the fibrosis present. And then we have the scarring present. So with the chronic infection, now the different changes which are lesions which are produced in the lungs, they become more serious, cavities are produced, and as a result of chronic infection, we have scarring and fibrosis. And this fibrosis causes tightening of the lungs, stricture formation, and the ability of the lungs to perform normal function, which is the ventilation, is also affected. And usually these patients will present with the hypoxia and hypercarbia. And then again we have complications associated with hypoxia and ischemia and hypercarbia also. So it keeps on going, and then we have different complications associated with the chronic infection. Next, another or structure which is affected by the infection is the meninges, and meninges are the coverings of the brain. We have three meninges covering of the brain and spinal cord. We have pia mater, arachnoid matter, and the dura mater. These are the three meninges, and the infection of the meninges cause coccidioidal meningitis, inflammation of the meninges. When meninges are involved, then there is constant persistent headache, because these are the coverings of the brain and spinal cord, and with the infection there is tightening, there is rigidity, and this causes the headache. Persistent headache is present. Lethargy is also associated with the meningeal involvement. Confusion. Nuchal rigidity, the stiffness of the neck because of the tightening of the meninges, that's also present. So there is nuchal rigidity. Lymphocytic pleocytosis, you can see these are the lymphocytes, and there is increase in the number of lymphocytes in the coccidioidal meningitis. So headache, lethargy, confusion, nuchal rigidity, and lymphocytic pleocytosis is present. Hypoglycorrhachia is also associated with the meningitis. This is decreased level of glucose in the cerebrospinal fluid. Hypo is low, glyco is for the glucose, glycorrhachia in the cerebrospinal fluid. This is the fluid which flows between the meninges in the brain and the spinal cord to give the protective cushion, and different tests performed on this cerebrospinal fluid, which is the fluid obtained by the lumbar puncture, in which the long needle is inserted in the between lumbar 3 and 4 to remove the fluid and to perform different tests, and you see decreased level of glucose in the cerebrospinal fluid. Then we have elevated protein levels also in the fluid. There is decreased glucose, elevated protein level. Cerebrospinal fluid eosinophilia, increased eosinophil, peripheral eosinophilia is anyway present, and in meningitis there is cerebrospinal fluid eosinophilia, increased eosinophil cells is present in the fungal infections. And then there is hydrocephalus. Hydrocephalus is enlargement of the head, and there is because of the there is hydrocephalus. So increased intracranial pressure, there is inflammation, and it can cause hydrocephalus. Hydro is for fluid, water, and cephal is for the head or brain. So there is hydrocephalus or fluid in the brain. Now the diagnosis of coccidioidomycosis, what are the different tests? Clues that suggest coccidioidomycosis infection. There is peripheral blood eosinophilia, very important clue that can tell us that there might be the infection, peripheral blood eosinophilia. Hilar or mediastinal adenopathy. Radiographic imaging. So the imaging of or the chest X-ray showing characteristic features with the scarring, fibrosis, cavitation, and the calcification is not present. So these are all the findings which might be helpful in the diagnosis of coccidioidomycosis. Marked fatigue is also present. And there is failure to improve with antibiotic therapy. Fungal infections require antifungal drugs. They do not respond to antibiotic therapy. So if the patient presents with the features like fever, and there is cough and chest pain, and without further diagnosis, if we start the antibiotic therapy thinking that it might be some bacterial infection, usually that infection or the fungal infection don't respond to the antibiotic therapy, and they need the antifungal drugs. So these are some clues that suggest coccidioidomycosis infection. Serology tests are done, which are the tests performed on the serum, like traditional tube precipitin, complement fixation assays, and immunodiffusion. So these are the tests on the serum that are helpful in the diagnosis. So tube precipitation, immunodiffusion, tube precipitation, immunodiffusion, complement fixation. So these are the tests which are done. Then enzyme immunoassay tests. Then sputum culture. Sputum culture is again an important test to culture the causative agent. Test for coccidioidal antigenuria and antigenemia. Presence of antigen in the urine and the antigen in the blood are also used for the diagnosis. Then genomic detection by polymerase chain reaction. So all these are the tests done for the diagnosis. We have some specific findings suggestive of the coccidioidomycosis, then serology test performed on the serum, sputum culture, test for the antigen in the urine and blood, and PCR or polymerase chain reaction. Next, treatment. As the causative agent is the fungus, the treatment is the antifungal drug, and very important effective antifungal is amphotericin B. dispersion with deoxycholate. Intravenously 0.7 to 1 milligram per kilogram, either daily or 3 times per week. Lipid dispersions. Intravenously 5 milligram per kilogram daily or 3 times per week. Then we have triazole antifungal drugs. These are itraconazole 200 milligram 3 times daily. And then we have fluconazole, which is 400 to 800 milligram daily. And then the ketoconazole 400 milligram daily. So all these are very effective antifungal drug, amphotericin B. Then we have triazole antifungal, itraconazole, fluconazole and ketoconazole, all very commonly used antifungal drugs. Next, the criteria for the treatment, we have symptoms persisting for more than 2 months. So that's the very important criteria. If the symptoms are present for more than 2 months, we should initiate the treatment for the infection. Then night sweats occurring for more than 3 weeks. Weight loss of more than 10%, and then a serum complement fixation antibody titer of more than 1:16. So these are all the criteria for the treatment. And also extensive pulmonary involvement apparent on the chest X-ray, and extensive pulmonary changes. We already know there might be a cavitation with the pus level, and there is fibrosis, scarring, and all these complications can cause different effects or features like dyspnea, and then we have cough, fever, and there is pleuritic chest pains. These are some criteria for the treatment of focal primary pulmonary coccidioidomycosis. If the symptoms are persisting for more than 2 months, night sweats for more than 3 weeks, weight loss is there, and there is extensive pulmonary involvement on the chest X-ray. So before we start with our second fungal infection, which is blastomycosis, let's briefly summarize our coccidioidomycosis infection caused by inhalation of the spore. And since it is caused by inhalation, the main organ affected is the lungs. 60% of the patients are asymptomatic. 40% are the symptomatic patients, mainly cause the pulmonary symptoms, which have cough, fever, shortness of breath, chest pain, and if the it affects other organs also like joints and skin. We can have erythema, nodosum, and erythema multiforme. Then we have involvement of the joints, causing arthralgia, arthritis. Peripheral eosinophilia is one of the characteristic feature of coccidioidomycosis infection, and then it can also involve the meninges, causing meningitis with headache, knuckle rigidity, confusion. So all these complications can occur as coccidioides infection. Then treatment is mainly antifungal drugs. There is no response to antibiotic therapy, and that's one of the indication that it might be a fungal infection. And some tests which are performed on the serum are the tube precipitin test. Then we have complement fixation test, immunodiffusion test. So all these tests are performed for the diagnosis. Then sputum culture is important, and then antigen levels in the urine and the blood. So all these are important in the diagnosis of coccidioidomycosis, and then we treat them with the antifungal drugs like ketoconazole, itraconazole, and then we have amphotericin B also. So next fungal infection which we will discuss now is blastomycosis, and this fungal infection is caused by the fungi or fungus known as Blastomyces dermatitis. And that's the picture showing the Blastomyces dermatitis, and it's the budding form. You can see it's budding and reproducing. Pathogenesis of blastomycosis, again caused by inhalation of the spores. Then inhalation of spores cause infection, and then there is recovery from the infection. It can be symptomatic pneumonia. Infection can cause symptomatic pneumonia caused by inhalation of the spores. So lungs again are the primary site of involvement causing the symptomatic pneumonia. Acute disease presentation. And then we have asymptomatic or unrecognized pneumonia also. Both conditions can lead to the recovery from the illness. Gradual onset of chronic disease, pulmonary or extrapulmonary. Reactivation pulmonary or extrapulmonary, and there is progressive pulmonary with or without extrapulmonary. So if I summarize this pathogenesis, there is inhalation of the spores causing the infection or involvement of the lungs, which will be of two types. One is symptomatic pneumonia-like infection, then we have asymptomatic or unrecognized pneumonia. Both these conditions, symptomatic or asymptomatic, will go into recovery, or patient will recover with three consequences that can occur after the recovery. One is gradual onset, and then it becomes a chronic infection, reactivation, pulmonary or extrapulmonary, or progressive pulmonary disease. So this is the pathogenesis of blastomycosis. The pathology, you can see that's the blastomycosis infection appearance, how it causes the lesion on the skin. And that's the pathological microscopic appearance of the lesion. You can see the blastomycosis fungus. So here, that's the fungi present, and that's the appearance on the body. Clinical features of blastomycosis, we have abrupt onset of fever. You can see the chest x-ray very congested, and there is also cavitation. And also there are the hilar markings, and there is a lot of congestion of the chest also with some effusions present. And so it's a bad condition, and there is lot of massive involvement of the lung parenchyma with blastomycosis. Then another is the chills, because fever is there associated with chills, because we mentioned it caused symptomatic pneumonia-like features, and pneumonia is associated with fever and chills. So chills are also present in blastomycosis. Then there is pleuritic chest pain because of extensive involvement of the lungs, parenchyma. There is pleuritic chest pain, very bad. Patient will complain of pain in the chest. As in the symptomatic pneumonia, we see there is pleuritic chest pain. And since we can see this X-ray and all these findings, we can see on this X-ray with the cavitation and pus and all that effusions. So chest pain is very likely to occur. Then arthralgias and myalgias, pain in the joint, muscle pain, body aches are also present. Cough is present in blastomycosis, and there is chronic indolent pneumonia. Next, diagnosis, how we diagnose blastomycosis. That's the microscopic examination, and you can see the blastomycosis on the microscopic examination. Then we have complement fixation test, immunodiffusion, enzyme immunoassay. All these are the tests we do for coccidioidomycosis too. So blastomycosis have the same diagnostic test. And then antigen assay for the blastomyces. Chemiluminescent DNA probes, repetitive sequence-based polymerase chain reaction. The treatment of blastomycosis, we have So the treatment of the blastomycosis, you will see we will divide it into immunocompetent and immunocompromised individual. And this first is immunocompetent patient, life-threatening disease. So these patients with pulmonary lung infection, they are treated with lipid amphotericin B or amphotericin B deoxycholate. Itraconazole, once patient's condition has stabilized, then we treat them with itraconazole. So immunocompetent patients, which are not immunocompromised, they are immunocompetent / life-threatening diseases. These are the patients with the lung infection, amphotericin B and itraconazole. Another is disseminated. One is just for the pulmonary when it is limited to the lungs. Then we had disseminated when it spread to the areas other than the lungs. For the central nervous system, we treated with lipid amphotericin B or amphotericin B deoxycholate. Then we fluconazole if patient is intolerant to full course of amphotericin B. Next, non-central nervous system disseminated is again lipid amphotericin B or amphotericin B deoxycholate and itraconazole. So in this case, we talked about the immunocompetent patient with pulmonary infection or disseminated infection. In the disseminated, we talked about central nervous system or non-central nervous system infection. Then the immunocompetent with non-life-threatening diseases. Another category is pulmonary or disseminated non-central nervous system. These are treated with itraconazole or lipid amphotericin B or amphotericin B deoxycholate, fluconazole or ketoconazole, and then immunocompromised patient. Fungal infections are very serious in patients who are immunocompromised. their immune system is weak, they have illnesses like AIDS or malignancies, or they are taking chemotherapeutic drugs. All these patients, their immune system is weak, and then how we treat these immunocompromised patients with all infections, we treat them with lipid amphotericin B or amphotericin B deoxycholate. And then itraconazole, non-central nervous system disease, once clinically improved. So different infections, you see, the treatment is mainly amphotericin B or itraconazole, sometimes fluconazole or ketoconazole. So the main line of treatment or main therapy for this blastomycosis is amphotericin B, itraconazole, and in some cases fluconazole or ketoconazole. So ketoconazole. So all these antifungal drugs are used for blastomycosis, mainly affect the lungs, but in some cases we see the disseminated cases of a cause symptomatic type of pneumonia or asymptomatic pneumonia. And that was all about our topic coccidioidomycosis and blastomycosis. Thanks for watching sqadia.com.